You may need someone to look under a few more stones for you. And I talked about how it can be easy for both parties, the physician and the patient, to sort of maybe take a seat and get a little comfortable, once your pain is controlled with the medication. Because once everything's settled in, the drive to keep pushing, the drive to keep looking and trying different things to get better, that drive tends to diminish over time, and we get comfortable. And so I think, speaking to physicians, we need to be aware of that also, but also patients as well. Because you feel good today doesn't necessarily mean you'll feel good tomorrow, so to speak. And so definitely we need to keep up the good fight, so to speak, to get to the root cause. So that's definitely a big part of it, and I think a lot of, for so long, our tools have been limited, right, in pain management. Everybody's familiar with the epidural steroid injection, the medial branch nerve block with the nerve burns and that type of thing. And I saw somebody in the comments this week, they mentioned how they were harmed because they ended up with, I don't know, what was it, like 6, 7, 8 steroid injections in the week? I'm sorry, not in the week, in the year. That's a lot of steroid injections in a year. And, unfortunately, that's not the first time I've heard of that. I've had another patient actually in my clinic talk about how she survived approximately 20 epidural steroid injections within about a 2.5 year period. And it's just like, at what point do you say it's not working? It's not working. We need to try something different. That's a huge problem I have, generally speaking, with pain management, because again, it's like, well, if these are all the tools you have, then, you just sort of keep hitting it until, you expect a different outcome. I don't agree with that. If something's not going to work well the first time, then you need to pivot, maybe try something else. Now, there are cases where you can repeat an epidural steroid injection, but not more than 4 in a year. That's where you start causing more damage than good, in my opinion. But anyway, I digress. That just boils down to the fact that, yes, you need a better plan, and you need a doctor that has more options in the tool belt, so to speak. And I've talked about that too. We have so many options now for chronic pain. It's unbelievable, and we'll get into that over the next few weeks. But that's the bottom line. If something's not working, you need a different plan, right? On Tuesday, we got to hear from Jose and learned a little bit about physical therapy and the role that activity and exercise has to play in getting better. And I did like one of the things he brought up, one of the points he made about the idea of, are we really compliant with our treatment plan? I can say for myself, I always start every year with the greatest intentions. And then 6 weeks in, I'm like, oh, well, I guess I'm done exercising now.
I'm trying to do the same.
Yeah. So totally understand that for sure. But it's a part of it. It's a part of a lifestyle that we're aiming towards. And it's okay if you take a break and you fall off the wagon. We understand that we're human. To live a functional life is to always get back up, always make that decision, whether it's 2 weeks late or 2 months late, it doesn't matter. Better late than never, right? But let me tell you guys something. I hear a lot of things from patients. What do you mean I have to do PT? PT doesn't work. PT just hurts to do. I'm going to waste a bunch of money, waste a bunch of time. For my pain, I don't think PT is helpful. I hear this a lot. If you're in the comments, let me know. Is that the experience for you? And then I'm going to answer that question with a little bit of a secret. You guys want a secret today? I'm going to tell you the real story about physical therapy.
Is it no pain, no gain?
Well, no. I never bought onto that statement. There is a good type of pain when it comes to exercise. Yes, that's true. And to differentiate that from pain and suffering. But no, it's not no pain, no gain. It is that physical therapy is not primarily for pain relief. It's not primarily for pain relief. And I think that we as a culture, certainly as a medical community and other doctors, there's doctors that know this, but the structure of our system is such that, well, before you qualify for the injection, you have to do 6 weeks of physical therapy. Before you qualify for the surgery, the knee replacement or whatever, you need 6 weeks, 3 months, 6 months. Some insurances now are requiring a year of active physical therapy before they'll approve a certain procedure. That's insane, by the way, but that's another story. No, we think that it's because physical therapy is going to help the pain first, and maybe then we won't need to do the procedure. But that's not really the purpose of PT. And I know this because I consulted my 3-inch thick pain management book that we were required to read in our fellowship. PT, physical therapy, is primarily to improve function. It's primarily to maintain function. And so if your pain improves as a result of doing PT, that is a secondary outcome. And so that's fantastic. But if you're feeling disillusioned about PT, I agree with you. I don't think that PT should be the primary gatekeeping therapy in order to advance the patient along the treatment protocol, let's say towards something that might be more effective or more definitive. Now, I'm not saying that we need to jump to more invasive treatments, but we definitely need to start conservative and work our way up slowly. Nobody's arguing for big spine surgery right out of the gate. Not at all. But I think if we're a patient that goes into physical therapy with the expectation that it's going to cure your pain, you may be disillusioned in that outcome. Not to say you shouldn't be optimistic. You should just understand it for what it is. So that's where PT sort of fits in for me. Primary outcome is function, improving function, maintaining function. Secondary outcome is pain relief. And so just to understand that for what it's worth, right? I think that can be huge. And we also talked a little bit about the difference of PT and strength coaching. And we're going to get into that definitely more later, because I think that can be a whole podcast. I happen to think strength training is much more effective for chronic pain, right? Jose was talking about PT for acute injuries and things of that nature. And that's true. And there's protocols and certain ways to approach certain problems. When you deal with chronic pain, the concept of an acute injury is diminished. It's not so much there. A lot of times people are hurting without any clear evidence of an injury. And that can be very frustrating. But that's where strength coaching comes in, because anytime that you can build up muscle, strengthen your core, your endurance, you improve your blood flow, you diminish your inflammation, you diminish your sensitivities to pain, and that's really where the benefit is, I think, for chronic pain patients. But we're going to get into that more later, and so yeah, that's where PT came in. When you're doing everything right, well, at least from this guy's perspective, it may just be a matter of expectations when it comes to those therapies. Wednesday, Katie had us all on our toes when it came to understanding nutrition and diet in our general health, and the big topic of the recent government shift in how we approach dietary recommendations. That was discussed. And of course, the big takeaway there is, while these recommendations can be broadly applied, if you're not getting better, it's probably because you need a more personalized plan, right? And that's huge. Our bodies are all different. Our blood types are all different. And how we metabolize things is different. And so, we need a custom approach to what we're putting in our mouths, you know. And then last but not least, we had Keith bring us home with the patient perspective. And wow, I'm always amazed when I watch Keith talk and hear his patients engage his patients. his followers engage, right? Everybody's a patient to me. Forgive me.
He almost comes off as a medical professional, though, doesn't
he really does. He really does. He knows. He lives it. He lives it. And mad respect for that he's able to pour into other people's cups in the way that he does.
Oh yeah.
And that's a huge reason, why we're partnering in such a way, because he can offer my patients and all of you watching, I think, a little bit something different than what a professional can offer. And so I will say this, though. I did have a small disagreement with him last night. And so if you're watching, Keith, brace yourself.
Oh, he's there. He's there.
No, my small disagreement is, and I think you're coming from a good you're coming from a good place. If you were talking about how you're going to the doctor's office, and if you can tell that the doctor's running around, like a madman, and clearly having a bad day, and as a patient, maybe that's not the best moment to bring up a concern, right? I understand where that's coming from, but your conclusion was that then you would wait a month suffering, essentially, to come back and then maybe reintroduce the idea at the next visit. I will follow you down this path. I will say definitely patients need to have grace with physicians just as much physicians need to have grace with patients. And that's the bottom line. But also, you as the patient are there for a reason. You're paying that office, that physician, for a reason. And because the patient or because the physician may be coming off like they're having a bad day is not an excuse for them to dismiss you or for you to feel like you can't make your needs known. The last thing I can tell you that we would want as physicians is 2-3 days later to hear that something really bad happened to you as a patient because maybe you didn't bring up that concern in the visit, because as a physician I didn't make you feel like you were able to or you were safe to. Don't do that. Talk to your doctor. Bring up concerns. There's nice ways to do it. I can tell you as a physician, I'm almost constantly running late. It's probably my biggest problem. One of my biggest problems is running late to patients' rooms. And when a patient gives me grace in that moment, I can tell you how amazing that grace feels on my heart, even if nothing is said. I know you're busy as a patient. I know you got things to do. And, I'm trying to get to you as quick as possible. I promise you. Because I don't want any patient to feel dismissed, right? We always want to sit down and listen and get to the bottom of the issue. Sometimes that results in the visit taking longer than planned. But I promise you, if I'm late to your room, I'm going to give you the same opportunity that I gave the prior patient. And when you start off with, I'm glad you're here, and you give me that grace, I'll tell you what, man, that feels so good. We're going to get to the bottom of it. And I appreciate that from my patients. And I'm sorry I'm late. I really am. But that's where it should be. But you should never feel like you can't bring up an issue with your doctor if it looks like they're having a bad day. We're grown-ass adults, okay? This is the job we signed up for. And if your doctor's not giving you that time of day or yelling at you or making you feel lesser than, that's inappropriate. And there should be grace on both sides. So that's my 2 cents on that, Keith. Not a major disagreement, but I just wanted to give the physicians give the patients, the viewers, the physician side of that fence and say, no, that's not okay. You do need to be able to make your needs known. So that's the recap on this week. I thought it was a great first week. We had some technical difficulties, but hey, like I said, we're in healthcare. We're figuring it out, okay? And I appreciate you guys signing on for this. We have a great next week planned, by the way. The challenge of next week is when pain intensity reflects tissue damage, or does it? Does pain intensity reflect tissue damage? So we're going to get into that concept and see how we can really understand our pain more, because we can't always live without it, and pain is very scary. And the more that we can understand a problem, I think the less scary it gets. And the less scary it gets, heck, the better we feel, right? It sort of feeds into itself. So that's what we're going to be talking about next week. On Monday, on my show, 7 p.m., I guess assuming the world is still here, doesn't totally freeze over, we're going to talk about how imaging plays a role in diagnosis and how imaging plays a role in understanding our pain and really understanding what it means when you have a disc herniation, what it means when you have bone-on-bone arthritis, and how we can rationalize that in our treatment plan. So stick around. I hope you guys stay nice and toasty this weekend. Make sure you guys have enough food on hand, and I will see you Monday. Y'all take care. Thank you.
And on a side note, thank you for your patience as well. We're getting comfortable with this thing now.